So how do I choose among the three different PARP inhibitors? Well, obviously with rucaparib having its unique indication with the somatic and the germline indication for patients with measurable disease that are not in a maintenance setting, that drug has its unique indication there. So if you have a somatic BRCA mutation, that's really the only drug you could use in a treatment type phase at this point. Olaparib we can use in a germline BRCA population after 3 prior lines of therapy. And then we have the maintenance indications that are similar between niraparib and olaparib, that after 2 prior platinum compounds in a CR or PR, those drugs can be used. As far as choosing which drug to use, there may be some hint on how they did on their most recent platinum drug or what their most recent therapies showed. If they had a lot of platelet problems, we may choose to not use niraparib, although I don't have any good data about that. We're just a little more nervous about some of the platelet toxicity of niraparib in patients that had a lot of thrombocytopenia. So I might choose olaparib in that population. The patients that have a lot of baseline nausea, it may drive the single-day dosing strategy of niraparib, where those patients can take one dose right before bed, and they maybe perhaps don't suffer quite as much nausea. Patients with hypertension, you may make a choice away from niraparib, as we do know that it can worsen hypertension. But outside of that, the differences are kind of mostly in style and maybe not as much in substance. The dose intensification, perhaps with niraparib, may make a difference, especially in those non-gBRCA, non-HRD population, where maybe that extra dose intensification may be making a difference.
So in the maintenance setting, when I'm evaluating a patient for a PARP inhibitor, the 2 drugs that are currently FDA approved in this setting would be niraparib and olaparib. And some things that I take into consideration include dosing. So niraparib is once a day, and olaparib is twice a day dosing. And I also look at the side effect profile for both drugs. In the treatment setting, it varies depending on if a patient has a germline BRCA mutation or if it's germline or if it's somatic. So if they have a germline BRCA mutation, they're eligible for either rucaparib or olaparib. But if they only have a somatic mutation, then that makes them eligible for rucaparib. And again, I look at side effect profile and quality of life and what the patient wants. In terms of the data that we have from the PARP inhibitor trials, it appears that patients respond better to a PARP inhibitor in the setting of platinum-sensitive disease, a germline or somatic BRCA mutation. So I think it makes sense to try to put patients on PARP inhibitors earlier on before they become platinum resistant. So that's why I tend to currently use them in the maintenance setting.
Olaparib and niraparib are approved for the maintenance setting, and I choose between those 2 drugs if I have a patient that has platinum-sensitive recurrent disease. Niraparib does cause a fair degree of thrombocytopenia. If I have a patient that is severely bone marrow suppressed and cannot recover from the severe bone marrow suppression in a timely fashion or within 8 weeks as recommended by the FDA, I might choose olaparib. Niraparib otherwise is a drug that was studied in a patient population that included not only BRCA1 and 2 mutation carriers, but all comers, and as outlined before, the NOVA trial clearly shows a benefit for all patients regardless of HRD or regardless of BRCA1 2 mutation. So I tend to choose niraparib if I see that the patient will tolerate this drug. Rucaparib and olaparib are both approved for the treatment of ovarian cancer patient with recurrent disease. If patients have BRCA1 2 mutation, I strongly consider either one of them. If there's no germline mutation and I see a somatic mutation in the tumor, then rucaparib is my drug of choice since it's approved for this indication.